Okay, I think for the purposes of time, we're going to get started. I'm obviously not Peter Reed, but I'll moderate this session. We've done a little swapperoo. Having said that, the talent or the speakers are the same order. So our next talk is patient safety aspects in trauma. It's going to be given by our friend and colleague, Dr. Rubiano from Mexico, who you all met yesterday and gave us a great talk on damage control. So with that in mind, Dr. Rubiano, we should get started.
Bueno.
Thank you very much for the invitation. We're going to speak about safety issues or safety aspects in trauma resuscitation. Just to remember a few concepts about patient safety, which implies the risk reduction of unnecessary harm associated with healthcare to a minimal acceptable level. Now, the question is, what does that level imply? It refers to the collective notion that is of each and everyone in the team, according to the current knowledge, the available resources, and the context in which care is provided, weighed against the risk of non-treatment. The word context is very important because it leads to the concept that patient safety depends on the site where we are. It is not the same to speak about patient safety in a hospital with very low resources than a hospital with a lot of resources. It also depends on the training and resources available and the protocols and many more elements. Where we have a higher risk for unnecessary harm associated to healthcare. In environments which lack of organization, in environments with lack of information registry, and here we relate to previous presentations speaking about the importance of keeping a registry of the processes. Environments with lack of surveillance and research, that is also an environment where we increase the risk for unnecessary harm in healthcare services. And then here we have the involvement of the institutions without a quality improvement program in trauma. And also an environment with lack of continuous medical education. So when we speak about the context, we have to look at each and every site where we offer trauma care services and see what item is met or not at the time of servicing the patients. We already mentioned yesterday something about many areas of the world at risk that do not meet many of those criteria. There are several studies showing areas in the world. By looking at the map, once those in the darker color do not meet many of those criteria, they have little organization, only a few opportunities of CME, a few quality improvement programs, and that increases the possibility of affecting patient safety. What factors are related to the failure in the service? There are factors of the individual related to the clinical knowledge and skills, the cognitive biases, the state of health, and human factors. There are others related to the process, the communication, the healthcare environment, the resources available, and the organizational factors. All of them could impact our work and could create issues to the patient. Some studies have been carried out to detect the most common errors at the time of servicing our patients. Most of them are related to elements that could be corrected, but that are difficult to be corrected because they have to do with the human factor. One of them is the communication error among the team. It is present in many areas where we don't have an organized trauma team, and simply a team gets together at the time of serving a patient, and quite often there are differences among the people serving the patient, and the egos as human beings prevails over the communication that is supposed to be effective. So we may have some personal hard feelings among the doctors, the nurses, the respiratory therapy staff, and when they have to work together, they put their egos over the importance of servicing a patient. We may have some errors of omission, and that's why we need a safety checklist, because our memory could fail, and sometimes we rely too much on our memories to make critical decisions, and memories could fail, and we could forget things to do. We may have commission errors related to training and selection errors, especially in the absence of guidelines and protocols to work on the patients. I may have an idea of how to treat a patient, but if I don't follow a protocol or an evidence based guideline, I could make wrong decisions. So, what are the most common pitfalls in trauma rooms? Malfunction of monitoring equipment. That happens a lot in low and middle income countries where we don't have resources to repair the equipment or to service the equipment properly, to have a good calibration of proper monitoring. It is something as simple as a non-invasive pressure. Many hospitals in the world have a single bracelet for all the patients, the pediatric patient, the big patients, and we know that a bracelet should be according to the size of the person. But in some hospitals, they have a single bracelet that is even too small for big patients, and that could alter the results of the non-invasive pressure. Lack of control of oxygen saturation, failure to immobilize the patient, the use of incorrect algorithm or protocol in case they have them, because sometimes they don't even have them. Failure to control glucose levels, failures in recognition of neurologic impairments, failures in the detection of misplaced endotracheal tubes, and the use of wrong drugs or the wrong dose of medication. When we work as a team, there are many problems, especially when coordinating the actions. That depends a lot on the personalities of the team. The surgeons of trauma tend to have a quite proactive personality, and they try to impose their views without arguing them. So it is important that every time we make a decision on a critical patient, to be able to take suggestions and listen to a different opinion. There are many elements related to teamwork, cultural matters, and many more. To work together in a resuscitation room does not um, imply that we have a good teamwork. Many hospital in many areas of the world in the trauma room we have a lot of people. We have students, residents, and a number of people that are not working as a team. And since they don't work as a team, we may end up with failures in the process that may have a poor treatment of the patient. We have importantly a study all of that interaction and the role that every person plays around the critical patient in the trauma resuscitation room. And let us remember that we're talking about people, but especially we have a role for every position. And regardless of the person around, there is a role to fulfill by that person. So that could vary according to the context. And as we said, a trauma team could be as effective with 3 or 4 people as it is with 5 or 8 people. But it is important to recognize that they all play a specific role. There are elemental aspects, like the fact that we may have an LCD screen with a very small screen. The possibility of making mistakes is much higher than when we have a bigger screen. That is something that is not understood, and when we visit many hospitals around the world, the decision making process to purchase the equipment is based on the cost and not on the impact of that equipment. And we have many emergency and trauma rooms where they make a decision to purchase the lowest cost equipment with a smaller screen instead of buying a bigger equipment with a bigger screen to make better decisions at a critical time. The information registry during the active stage of resuscitation is critical, and there are many barriers to understand in the administrative process that a single person in the team should be solely dedicated to gather the information from the resuscitation room. That has been addressed in many areas with the cameras recording the resuscitation process that can later be reviewed. But if we don't have that system in place, it is critical to have a registry, and there are systems like those mentioned by Dr. Morat with the possibility of real-time information gathering to be assessed later. The white boards who populate minimum information are critical because that prepares the team mentally to be organized around the patient that is going to arrive. If we have minimum information in the resuscitation room about the vital signs, age, trauma mechanism, that could help a lot the team to be ready for what they're going to face later. Those systems obviously change, and that's why we talk about the context. In some areas of the world, they simply have a sheet of paper and a pencil to take notes, and in other areas, they may have IT systems with multiple data centers like the ones we saw before. And obviously, the more organized and systematized we have the information, the less we're going to have human mistakes. Because it is clear that when we speak about those topics and we know that the human factor is critical, we should talk about human mistakes. We could fail as humans, especially if we rely on mental processes that are altered by the emotional components. many of our memory processes and decision making processes are physiologically altered by the emotional components. And if we are affected emotionally, the decision making process could be affected also. There should be a team that supervises the processes periodically and that checks the information to assess what's happening during the trauma resuscitation process. And that's what the quality team performs as a trauma team. We all know the model of the era, the moments where we could stop ourselves and define if what we're doing so far is the best for the patient. And if we don't have those breaks to assess critical aspects, we may overlook a mistake that could imply the death of the patient. This has been investigated and is part of the new generation of trials. Every time we try to establish the elements that affected the outcome of the patient, one of those indicators should be related to the human element. And the new systems with multiple analysis could establish, for example, if that day was a day where the junior resident or the senior resident was on duty, and if that impacted the outcome of the patient. That wasn't taken into consideration in the past because we assumed that the fact that there was a doctor there could mean the same in every case. And now we know that we need to assess that human component as part of the resuscitation process. The final impact is the result of teamwork. We could be the best trained people with the best knowledge, with the best surgical skills, but we are not going to change the outcome of the patient on our own because we are not going to be round the clock, the 7 days of the week, the 365 days of the year, next to the patient's bed. We need to go to rest sometime. And that is why we have shifts and duties in the hospital. Another person is going to replace us to have a comprehensive management of the patient. So it is ultimately teamwork, and we expect everyone to perform in the same way because we want to be successful and we want everything to go smoothly, but to work as a team, there are many human elements to consider, and we see that in the sports teams. So that element of the environment, we have determined the assessment of the care environment. That is going to be part of the elements to be considered in future researches about the impact of the team and the resources on the functional outcome of the patient. The work that we see below was something that we developed with around 400 patients of trauma in a southern hospital of Colombia, where we implemented the protocol of initial care and we assessed the impact and the outcome before and after the protocol. The protocol was organized based on many of the guidelines we have already heard here. The small volume resuscitation protocols, the early use of hemoderivatives or blood derivatives, and surprisingly, we found out that of all the team working in trauma, only 40 to 50% of the teams comply with the care protocol. There were many people that though they received the training and they said that they would comply with the protocol, they did not do it. And when we asked why, the reply was fully related to human elements. They had nothing to do with the academic procedure. They did not say it is that we don't want to use early blood because there is no evidence, or I don't want to use a low volume of crystalloids because there is no evidence to support it. The responses were, I don't want to comply by that protocol because there is a person there that I don't get along with, or I don't want to comply with that protocol because the day they signed the document, I wasn't present and I wasn't invited. So all of the replies had to do with the human element. We found responses like, I've been doing the same thing for 30 years and I don't want to change the way of doing things. So if we assess those responses, all of them are centered around our egos and everything revolves around us. And we never think about the patients. At the time, once we understand that the patient is more important than us and that it goes beyond our goals because we're working on that patient, probably we'll be able to improve many things around teamwork. You all know the exercise of the surgical safety checklist for surgery, and by the end of the year, we expect to publish the results of the first pilot study with a trauma care checklist in 13 institutions around the world. Um, it proved how organizing care and having minimum points to remember how to proceed in the resuscitation process could change things. Some examples that prove that the only thing you have to do is to place that checklist on the resuscitation room. Once again, we go back to the human factor that was repeated. In many centers, they wonder who is the best person to prepare to work on the checklist during the trauma resuscitation. And in principle, everyone said the doctor heading the process is the ideal person to work on that list. But in practical terms, the doctors said we don't have time. Taking the checklist could take time from us. So we said, good, okay, who is the best person if the doctor doesn't want to do it because it's going to take time from them? So we asked the nurses and they said, yes, we're going to be in charge of the checklist. They began calling aloud the checklist and the doctor said, I don't want to be assessed by that list because I know things better than the nurses. So always the human factor is involved. And that element of interaction eventually impacts the patient. Critical elements in the process to exercise proactive leadership, where the people leading the resuscitation are actual team leaders and not a person because it's speaking louder and people are afraid of that person because that is not the ideal situation for this. So it should be the person that offers the team harmony. It is a mutual situation monitoring for every member of the team because we're all looking at this from a different perspective. The mutual support and the effective communication. What we need to work on, according to what we have assessed, to understand that there is a human factor that should not prevail over the goals of the team for the patient. We need to change our mindsets. We need to have an open mind for those changes to happen and the effective communication. And see that many of those aspects are not related with a huge infrastructure or resources. Most of them could be changed if we have a mentality of change. The way we treat other people depend on ourselves, how we treat each other, our patients, our possibility to be more tolerant, the possibility to understand that we are not the last human being in the universe and that the whole universe revolves around us. No, we revolve around the universe and we're just a tiny part of the whole teamwork. We're already publishing some articles with the results of those processes. Definitely, changes can be made for the benefit of the patients, and that goes hand in hand with the technology that we use to assess those processes. We have the technology, but we need to become part of that change. We need to understand that we act as members of a team. Thank you very much.
One quick question. There's an internet question here that asks, do you see a role for team steps in trauma care? Thank you.
Definitely, there is an element that could help integrate and change all of this. A lot of this has already been applied in the ICU, where we have critical elements to improve. And it is an element to take into consideration for the organization. We know that the organizational and functional parts are important, and all of that is part of the change.